Good evening. Let me begin with acknowledging that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We also acknowledge the histories, contributions, and legacies of the African Nova Scotian people and communities who have been here for more than 400 years. Hi, I'm Brenda Merritt. I'm the Dean of the Faculty of Health here at Dalhousie University and host of this evening's Open Dialogue Live on improving access to pediatric health care in Atlantic Canada. Our health system works for many, but not all. There are currently over 30,000 children aged 16 and younger who do not have a primary care provider in Nova Scotia. Additionally, families from underrepresented and underserved communities across the Maritimes often do not achieve the same health outcomes as others because they may not have the same resources or access to care. Dalhousie is the nexus of health-related research, education, and outreach programs in Atlantic Canada. With faculties of medicine, health, and dentistry, the university has a concentration of health disciplines, one of the country's largest. This creates a vibrant and collaborative community of professionals who are dedicated to improving health outcomes and building strong health systems. Through health education, more accessible care, and driving health research that creates evidence-informed solutions for individuals, populations, and healthcare systems. Tonight's engaging conversation will tackle questions around improving access to pediatric care in Atlantic Canada. And for those online, we have a vibrant group of people here in the room, and we will try to keep engaging with those who are online as well. I'm going to start by introducing our panelists. We have Shauna Hachey. He's an associate professor in Dalhousie School of Dental Hygiene and co-lead of the Dalhousie Healthy Populations Institute Putting Oral Health is Health into Action flagship project. Her research interests include the integration of oral health into primary and continuing care settings and novel community-led oral health promotion and knowledge translation. And I'm going in order down the line here. The next panelist is Karlee Francis, is the health director for Eskasoni First Nation, located in Unama'ki in Cape Breton. She is a fluent Mi'kmaq speaker and can also read and write in the Mi'kmaq language. She is an advocate for health at the local, provincial, and federal level. Next, we have Dr. Andrew Link. He has been Chief of Pediatrics at the IWK Health Center and Department Chair at Dalhousie University since 2016. He has long-lasting experience in results-based health advocacy and interests in public policy, physician leadership, global health, and patient safety and quality improvement. And last, we have Dr. Sarah Moore, is an assistant professor in the School of Health and Human Performance, but now associate, right? We're there? July 1st, okay. I always like to celebrate a little bit of those accomplishments. Assistant professor in the School of Health and Human Performance in the Faculty of Health. Her research expertise is in childhood disability, health and well-being, adapted physical activity and physical rehabilitation, childhood growth, development, and maturation. So those are our panelists for this evening. And I'll start off, we'll have a few opening remarks for each of our panelists for the first half hour or so. And then we'll open the floor to questions from our in-person and online audience for the remaining 15 to 20 minutes. We may not be able to answer all of the questions depending on the volume we receive. And for those in the room, and I think online, there is a QR code that you will submit your questions through. We won't field any questions by hand, but all through the QR code. Okay, we have a lot that we want to get through tonight, so let's begin. We'll start with Shauna Hachey, and with the question, what does improving access to pediatric healthcare in Atlantic Canada mean to you with dental hygiene and dentistry?
So first, it's important to recognize the importance of oral health. And second, to identify the barriers for those that are experiencing barriers to access to care and experiencing higher burden to oral disease. And lastly, to identify strategies to address these disparities in access to care for priority populations. So oral health is the ability to eat, drink, communicate, and express emotion free from pain and disease. And pain and infection resulting from severe decay can affect a child's ability to eat, sleep, talk, learn, play, socialize, and result in time missed from school, and ultimately can limit one's ability to grow and to develop. While dental decay is generally preventable, it remains the most common chronic disease among children in Canada and is the leading cause for day surgery under general anesthesia. Day surgery to treat dental decay is experienced most often by children living in less affluent communities, those in rural areas, and those that are from neighborhoods with a large proportion of Aboriginal children. This demonstrates national inequities in oral health based on income, geographic location, and race. In Atlantic Canada, dental conditions are among the top 3 reasons for pain diagnosis among children and youth and are significantly more likely to occur among First Nations children and youth. Children who have early prevention are less likely to need tertiary care, including emergency visits and trips to the hospital for oral surgery under anesthesia. Ensuring the first visit by age 1 and establishing an ongoing relationship with an oral health provider is critical, yet only 31% of eligible children benefit from Nova Scotia's public dental insurance for children, and few seek care by the recommended age of 1. So for me, improving access to pediatric health care in Atlantic Canada means a multidisciplinary, multi-pronged approach that prioritizes populations most likely to experience barriers to care and poor oral health outcomes. So in addition to promoting the first visit by age 1, strategies to improve access may include efforts to reduce the underlying determinants of health, such as child poverty, investing in surveillance data to monitor and inform public programming, investing in oral health care and primary care, such as incorporating oral screenings and education into well baby visits, and adopting models of care that include oral care providers such as the North End Community Health Centre. Allowing all oral health providers to bill dental insurance for their services, implementing preschool oral health screening programs and school and community-based services, promoting fluoridation programs, both water and varnish, as currently almost half of Nova Scotians do not benefit from water fluoridation. And lastly, more efforts in translating and mobilizing knowledge using culturally relevant resources such as Baby Smiles.
Thank you. Next, we have Karlee Francis, and the question is, what does improving access to pediatric health care in Atlantic Canada mean to you as the Director for Eskasoni First Nation?
Thank you, Walalin, for that question. For me, specifically, it means healthier children receiving adequate services at a young age, from infancy to adolescence. And specifically, it also means children receiving safe care, culturally competent care when accessing services at primary care, hospitals, children's hospitals, and more specifically, even seeing more First Nation providers, specifically Mi'kmaq providers, those that speak the language, is also another important piece for many of our children that are accessing care, because without that, there's a difficulty, and it impacts that care that is provided to them. So that's specifically important, especially because of the historical trauma of our communities and the colonial policies that have taken place federally, Indian residential schools, Indian day schools. So, the importance of those providers to really understand and have that knowledge when interacting with their patients is really important, and could really improve their care. And more specifically, I think another way is to be able to address those current health data that currently exists in our First Nation communities, and being able to act on that and providing a solution based for our communities, that we just don't have this data sitting there on a desk, but action put towards it. And I know there's been a lot of initiatives that have taken place and that are currently taking place and working towards addressing those barriers currently. And lastly, I just want to say the importance of working closely with community and community voice is really important, because the communities are the ones who know best of what's currently happening. So having that too, I could see, an improvement for pediatric healthcare.
Thank you. And Dr. Andrew Link, what does improving access to pediatric healthcare in Atlantic Canada mean to you at the IWK and Dalhousie?
Thank you, Dean. Everybody, including children and their parents, deserve access to timely quality services, especially in primary care or even in specialty care. If we catch problems early, be they disabilities or chronic illnesses, or we get vaccines on board early, that prevents a lot of suffering and long-term disability. About 20% of all children have at least one chronic illness. It could be asthma, it could be ADHD, it could be anxiety. All of those things can really interfere with quality of life, and they can also affect the trajectory when they become adults. And we know that if we get the kids early and help them out, they become healthy adults. If we don't have nice support services for pediatric care, sometimes they end up living in tents downtown in our cities as well. And I've seen that through many decades of being a community pediatrician in Cape Breton, the kids who had good access and those kids who didn't have good, consistent access. So some of the issues that we're dealing with right now, and Dean, you mentioned this in your opening remarks, are access to primary care. So 15% of the population in Nova Scotia, we have 1 million people, don't have access to a regular primary care practitioner, be it a nurse practitioner or a family doc. And knowing that 20% of the population are under 16, that's 30,000 kids in Nova Scotia, half of whom live here in Central Zone or HRM. We also have long wait times right now for consultant care. So if your child's had a seizure, or they have some chronic serious belly pain, or if they have a learning difficulty at school and they're having trouble, long wait times to get in to see a specialist or a general pediatrician right now. The other thing that pediatricians and pediatric health cares also pay attention to are the social determinants of health. So it's not enough just to treat kids in your offices and the hospitals. I'm on doing inpatient service right now, but we spend a lot of time and work, and some of us along the table here have been involved with the One Chance to Be a Child report that came out about 2 years ago. We have 1 in 7 kids in Nova Scotia who are living absolutely below the poverty line. And what are their trajectories like? We're pushing to have a child and youth advocate for all of Nova Scotia, perhaps partner with our First Nations colleagues as well, to make sure we put an emphasis on children. All of us older baby boomers, I keep saying, are going to suck the place dry of resources, but we also have to make those early investments for the next generation coming up. If we want to attract the best and the brightest to Nova Scotia for immigration, they're going to want to know, do they have a family doctor? Can their kids who've got asthma get in to see a pediatrician easily? It's a competitive thing that's also in our best interest to have that part solved as well. What else would I say, Dean, just to sort of wrap it up a little bit? I have lots of solutions I'm very confident about. We're just starting some things. I don't know if we should save that for later. Dean, I don't want to hog things here right now, but
maybe at this point we'll focus on the access, and then we'll dig deeper.
So those are the access issues, and I'll give you some exciting updates on how we can address these issues in a little bit of time. I'll hand it over to Dr. Moore.
All right, so Dr. Sarah Moore, what does improving access to pediatric health care in Atlantic Canada mean for children with disabilities?
Thanks, Dean Merritt. The first place that I went to answer this question were the kids and families that I work with on a regular basis. And one of the most striking comments that I heard from one of our kids was that healthcare is not for me. And so that was pretty impactful and not surprising, but certainly something that I think we need to do something about. So overall, I summarized some of the comments from the kids and families that I work with, and it really came down to access, but also to inclusion. So for example, access was a huge concern for a lot of our kids, being able to access care, a primary care physician, as we talked about, but also specialty care. There was concerns around wait times. There was concerns around being able to access if you live in a rural or a remote community, specifically for specialized care. In addition to that, our children talked about that there were certain individuals, even kids that lived with disabilities, that had additional barriers, for example, newcomers. So how do you access healthcare if you're a newcomer? How do you ensure that you can get access to specialized equipment or specialized care if you are a newcomer to our province? In addition to that, there's a lot of limitations around funding that they talked about. So if you do get access to services, and you are prescribed a wheelchair or a walker or some other type of assistive equipment, how do you access that equipment if you don't have extended benefits? Well, you may go through loan programs that may or may not have something available to you or may not fit you with the correct types of equipment, which makes it uncomfortable or not fun. In addition to that, they talked about the lack of services between inpatient and outpatient care. So being able to transition between inpatient care and out to the communities, particularly when they lived in rural and remote areas. In addition to that, something else that came up was the idea of transitioning between developmental milestones, so transitioning to adolescent care or transitioning to adult care, which was a huge concern, something that is thought about by parents and children very, very early on when you live with a disability. So in terms of creating inclusive care, some of the things that I heard from our kids and their families was really thinking about practices being informed by lived experiences. We heard this from other members of this panel. How can we ensure that they are informing how we provide care, how we think about our care models in different practice settings? In addition to that, thinking about practices across all transition periods and really ensuring that we're working for child-centered and family-centered care to be able to move towards health equity.
Thank you, Sarah. Thank you to the panelists for starting the conversation. I'm going to now ask each of the panelists a detailed question about their field of work. After this conversation, the question and answer session will begin. And just a reminder about the QR code. All right, so we'll start with Shauna Hachey. Could you talk about your work on the Baby Smiles and the partnership with Dweejin Partnership and Dajagimic, the Mi'kmaq Health and Wellness? What were some of the major learnings while working on the book and the access of information for new parents?
I'll talk a little bit about the project to start. So this work began when the health directors in Unama'ki, who are collectively referred to as the Dweejin Partnership, identified, based on the data I had discussed earlier, that one of the greatest concerns was oral health in the community. And when community members and leaders and healthcare providers were asked about how to address oral disease, as Karlee mentioned, looking back to community members who know best, one of the solutions was holistic wellness, positive-based oral health promotion, which brings us to Baby Smiles. So Baby Smiles, kind of the main output of this project is the book that you see before me, and it supports the oral health of Mi'kmaq children ages 0 to 3 and their caregivers, as well as aims to preserve and promote Mi'kmaq culture and language. And so to our knowledge, this book is the first of its kind. So it was created in partnership with Dajagimic, which is the organization tasked with health transformation for Mi'kmaq communities in Nova Scotia, and collaborators from Dalhousie, including myself and doctors Mary McNally and Margot Latimer. Since the launch in April of this year in Wagmatcook First Nation, Baby Smiles has expanded to a provincial program in all 13 communities, and it is also included in the Mi'kmaq Bag and the Read to Me program across the province as well, which is work we're very proud of. So just a few kind of maybe interesting details about the book itself. So the artwork is by Loretta Gould, and if you're not familiar with her work, you should check it out. If you have gone through the airport recently, she has an art installation that is there, and so somehow we managed to get her to come on board, which was really exciting. We purposely didn't use the terms mom and dad, just to be inclusive of that every family looks different. There is an oral care provider in the book, and we purposely made this individual look a bit androgynous with both male and female characteristics, because the first experience with a provider may be a female, it may be a male. We consulted a lot with other community-based programs to make sure that our messaging aligned. So, for example, the Head Start program, the nutritionist in the community, to make sure that we weren't just promoting oral health, but we were promoting overall health and wellness. We also have a book in a page in the back that relates to kind of each of the key messages that are promoted throughout the book, but more detailed information for the caregiver themselves. And we have the project is hosted within the Dodgegamig website. So each of the book has a QR code inside, which will bring you to our webpage, which has a free downloadable version of the book, and it also has audiovisual versions of the book in both English and Mi'kmaq. And the voiceover is done by Anne-Marie Marchand, who's a voice actor in and works in. She is the principal of Baladek. There you go. And she also has a cartoon that she does the voiceover work for called Little Teepee. So we're very excited to have these community members come on board. And I think that's it. Somebody's telling me to stop.
Something in the room that's drawing attention to us. It has stopped now. Perfect. Okay, we'll move on to Karlee. While being the health director and a member of Eskasoni First Nation, what would be some of the major barriers to access to health care for children and their families?
I think the greatest barrier is the jurisdictional barriers that currently exist when you're from a First Nation community. So oftentimes, we have this big health system, but then they say, that's a federal responsibility, that's a provincial responsibility, but then not thinking about the child at the center. And, the greatest example is Jordan's principal, Jordan River Anderson, who was from Manitoba that needed home care service. And at the time, he was at the hospital, and, the province was, and the federal, were fighting between who's going to fund this service, not thinking of the child at the center, and that child ended up dying at the hospital, not ever being able to go home. So that's come about with Jordan's principle that every child deserves adequate services, no matter whether if you're from a First Nation community or not. And that's something that we currently face on a daily basis, even in today's society. So that's something that we're really working towards, especially as health leaders and health leaderships on, how can we break those barriers to work together collaboratively, build those partnerships innovatively, and, not having to reinvent the wheel, but working together collaboratively. And that's something that we're currently working towards. Another piece is on the lack of specialist services in community. So in our, First Nation communities, we're not equipped with specialist services in the community, and I think that, that's a future goal, is to have specialists be able to come into the community, whether if it be through in-person or telehealth, to be able to meet the child there at the center. Because another big piece, and I think Dr. Andrew Link noted regarding the social determinants of health, there's a big barrier there on transportation, income. So just, for a child to go and see a specialist 4 hours away, that's already a big significant barrier for a child to receive that service. Again, as I talked about earlier regarding culturally competent care, oftentimes providers they don't understand, they have the lack of knowledge of colonial federal policies that have taken place years in the past, Indian residential schools, Indian day schools. And oftentimes what happens is, when that child is receiving the care, they encounter racism. That is, a big piece of a huge barrier in receiving quality care, because the child is now receiving services, but on top of that, now they have to deal with the racism that occurs on the provider's lens. So that's a big barrier in our community. Another big barrier is also the admin burden of non-insured health benefits that many of our First Nation community members have to use as status First Nations. And, you know, when accessing care, for example, for dentistry or for dental, you know, they're having to pay up front when that service is covered, just depending on the practice that they go to. So, you know, that's a big issue in our community. And again, the resource limitation in our communities, I would really like to see more resources in our community, more equipment, infrastructure to be able to serve our community members better. Eskasoni is the largest First Nation community in Nova Scotia and Atlantic. So, you know, there definitely are, I think we're almost at 5,000 community members. So even to be able to better serve them is my ultimate goal as a health director. And again, as I talked about the indicators that currently exist, you know, we have high ear, throat pain, oral, and mental health. And there are some initiatives that are happening currently, specifically the one at IWK, Aboriginal Children Hurt and Healing Initiative, that's working closely with our community on addressing these indicators that exist. And we have some exciting initiatives on the way, but again, there's definitely more work that could be done to improve service in our communities.
Thank you, Karlee. Next, we'll go to Andrew. As the Chief of Pediatrics at the IWK, what are the current trends you're seeing in pediatrics, and what are some of the major challenges to making pediatric care more accessible? And can you also share how Dalhousie is playing a role in solving these challenges?
Oh, easy questions. Okay, let's see what we can do here. All right. So primary care, as we spoke about, is a big issue for everybody. We're concerned about children and families who don't have access to primary care. People may not know, but 25% of our family docs in Nova Scotia are over the age of 60. And those tend to be physicians who have big traditional practices, like 4,000 people, whereas the younger family docs are taking, I think, 1,500 is kind of the cutoff. So we're going to see retirements and a lot of people who are kind of left out in the cold a little bit. So that's a big issue. We have a growing population, too. I think the Premier said a year ago he'd love to see Nova Scotia double from 1 million to 2 million by 2040 or something, and that might actually happen. But how are we going to have enough schools and tradespeople and physicians and nurses and everybody else to manage that? So that's a big issue coming up. So I don't think we're going to be able to close the family medicine nurse practitioner gap easily in the next 5 or 10 years without doing something innovative. So one thing that we're doing at the IWK and at DAL, and we, in fact, just today, about 2 hours ago, Dean, I got the email saying we've got the funding for it. So the province are going to allow us to hire, as a pilot project, a community pediatrician and a clinical assistant. That's often a physician who's trained overseas, come to Canada, doesn't have a full license. Those two are going to work in a family medicine collaborative in Spryfield, and they're going to take about 2,000 of the 15,000 kids in Halifax who don't have a family care doc or nurse, and they're going to be able to take them off the list, plus also be able to do some consultant care too as well. And then the next phase hopefully is to go to North Dartmouth and do the same thing and work within family medicine collaboratives with nurse practitioners. We can also be training centers for new med students, all the new family doctors, including from Eskasoni, all of our young medical students and nurses who are coming, that they'll have a place to train there as well. And plus we can address some of the vulnerable kids who have complex mental health and or physical issues who don't really have a home right now. So that's one thing we're doing. And that's just about to start. In fact, we're going to post for the pediatrician tomorrow, and I think in about a couple of weeks' time we'll post for the clinical assistant. The other thing is that when you're trying to make the world a better place, it's one thing to have passion, but you also need to have evidence. You need data. If you're going to go to the funders, you're competing with everybody else, so you need to do your homework. So I said, okay, we're making 5 new we're graduating 5 pediatricians a year from the IWK. 5 come in, 5 go out. One of those 5 become community pediatricians. And I said to myself, Andrew, is that enough? I'm not sure if we're making enough here at Dal. So I did a survey of all the regional pediatric chiefs across the Maritimes. So we're making 1 new community pediatrician a year. We have 10 vacancies right now. We have 10 upcoming retirements. And just to meet the wait times, I need another 8. So I'm not doing a good job. But I didn't know that. I felt it, but I didn't know it until I had the data. So my program director and I met with the associate dean last week. So I think we've convinced him that we're going to go from 5 to maybe 7 or 8 new intakes a year and make sure we expose those younger folks and hopefully First Nation folks and other med students to community pediatrics and get more of the young people out in the community to be able to do that important work too. But that took a survey, that took data. So that's one of the things. And I think Dalhousie could probably step it up in all of our health-related professions by doing good human health resource planning. How did we get in this mess with the family physician thing? Some people could see it years ago, but did we have hard enough data? Were we convincing people? Because now we're kind of in a bind. And the same might be true for nursing, although we're expanding our nursing schools, we're expanding our medical schools. But you can't just do that overnight, and it takes time and planning. So that's really important. The other thing I would just say is that when I was in Cape Breton, we noticed we had a lot of young women, 16, 17, 18, 19, having babies that weren't planned, unplanned teenage pregnancies. So we were able to put in now we have in all the 8 high schools in Cape Breton, including the one in Eskasoni, we have youth health centers. And that's a nurse there all the time, and a visiting family doctor or pediatrician comes. We dropped our teen pregnancy rate by 50% after doing that. And these are now adolescents who also have access to health care because they may not have family doctors. They may not want to go to a walk-in clinic. They may not even live close to a walk-in clinic, but they're at the school. They can go down to the youth health center that's youth-friendly and has youth on the committees, and they can access some of the services. The last thing I think to say is that we, for children in care, very vulnerable kids who are in foster care, they get moved all around the province. Their medical records, their health care is fragmented, and often they don't have primary care access either. We're establishing clinics across the province now just for those kids so they can have regular access and they get good care as well. And we've also put a pediatrician, thanks to Dr. Brent Young here, who is the director of medical director of Indigenous Health at the Med School in our North End Welcome Center for First Nations families and kids. So there's a pediatrician visiting there at least once a month to help Brent and the other physicians out there as well. And hopefully that will be a First Nations pediatrician pretty soon. Karlee's going to help me recruit because that's really important for all the reasons that Karlee's talked about as well. So that's it, Madam Chair.
Thank you. And next we'll move on to Sarah. Your research aims to improve children's health and quality of life through play and physical activity and has found that several adult conditions have pediatric antecedents. Could you explain how access to physical activity can have a life-changing impact?
Yeah, thanks, Dean Merritt. Well, first of all, I'll start by saying that the UN Conventions of the Rights of the Child and Persons with Disabilities say that play and physical activity is a right of all children with disabilities. Yet most of our kids with disabilities are not participating in physical activity and play throughout their childhood. There's facing play deprivation, in fact. When we look at our national data, so I'm part of 2 large national studies, the National Physical Activity Measurement Study, or NPAM, and CDPP, or the Canadian Disability Participation Project. Our data show that less than 10% of children are meeting the physical activity recommendations when they have a disability. Now, our numbers aren't that much better for kids without disabilities, but it's certainly meaning that 90% of kids with disabilities are not receiving enough physical activity and play in order for them to accomplish the health-related benefits that come alongside physical activity and play. When I'm talking about physical activity and play, I'm talking about things like cardiometabolic health, musculoskeletal health, social connectedness, but also other elements like our mental health and quality of life. So lots of different benefits that we know are associated with engaging in sufficient physical activity and play. So in terms of what we know is that when kids are able to engage in play and physical activity early on, they do achieve and accomplish those physical activity benefits. So they have better musculoskeletal health, they have better cardiovascular health, they have better social connectedness, they do better in school and academics, and they often are able to bring those physical activity behaviors across into adolescence, into early adulthood, and then into their adult life. We know that those physical activity behaviors then accomplish some of those physical activity benefits, so for our health and well-being. For kids with disabilities, they're often disengaged, and there's lots of different barriers that exist for kids with disabilities. And so I've, again, brought this question to the kids and families that I work with. Most of the kids will say that there's not a lot of programs for them. I am part of Easter Seals, which is an organization here in the province, and we run 5 programs for kids with disabilities. We have a Learn to Wheel program, which is a wheelchair basketball program, Learn to Sledge, ice hockey program, a power chair soccer program, which is often our power chair users are even further disadvantaged when it comes to physical activity opportunities, and so on. And so the first thing is that they believe, this is from my kids saying this, is that there's just not enough programs for us to be able to engage. And so that's one of the things that's certainly a challenge, is that a lot of our programs that exist are not very inclusive to physical activity. When I talk to one of the kids that are on our disability advisory group, so we have a youth-led disability advisory group, and they provided me a story where they were disengaged in physical activity in their schools because when their class goes to PE, they go to the library. And so this is still happening. This is something that is commonly happening in schools. And so we do need to do a better job of making sure that our people working in communities, but also people working in schools, have enough awareness and competency to be able to increase their inclusive physical activity programs. So if we think about increasing physical activity for this population, which again, 90% of these kids are not getting enough physical activity, the health benefits can be even further magnified compared with children without disabilities in terms of their physical activity, because there's that many more kids that we can reach through this benefit. And so I do believe that we are able to create more of a lifelong benefit by engaging children with disabilities in physical activity.
Thank you. Thanks for kicking us off with those opening questions. So we'll move on to the question and answer session. And the questions are coming to me from my phone, so that's why I keep looking at my phone. And I do have one question to kick us off, which could spark some healthy debate. Is the fact that we have a public healthcare system the main reason that our access to care is so compromised? Would anybody like to start off or address that question?
Like a Dr. Link question to me.
There's some hard-hitting questions here.
So my answer would be no, I don't think it's the public health care, the funding part of it. I think it's the planning part of it. And I think we can do better. And whether you're private or you're public, you still have to do planning if you're going to meet demand and you're going to meet the supply part. So don't think they're linked. Are private enterprises more efficient? Maybe if they're profit-driven. I guess some people might argue that. Are they more just? Probably not. So I'm a big fan of the public system, but definitely we can do better. We've got lots of good young leaders. I see some of them at the table here right now that are trying to make the system better and make wise investments. Politicians have to make tough decisions about where you're going to spend money and things like that. And I'm biased. I think early investments in the early years pay dividends. I think there's even some good economic research to say for every buck you put in at this age, you probably save $3 or $4 or $5 later on in the future. So, but again, it's planning and being thoughtful and looking 5, 10, 15 years down the road about the trends, what we need, how we're going to adapt.
Thank you, Andrew. Anything else from, I have another question, but any other comments from the panelists on that question? Okay, so this question is for Shauna. Dr. Link commented on the need for greater training of medical and nursing professionals to meet demands. Do you foresee similar issues arising with access to oral health professionals with the new Canadian dental care plan?
It's a great question, very, very pertinent for sure, and I think it's on top of everyone's mind who is an educator in a dental program right now or a dental hygiene profession. In a way, it's a good problem to have because as we increase access to care, we of course want people to be using our services, but most definitely it will be interesting to see how we meet the demand of the up to 9 million people who will have access to care that may not have had prior to this plan coming into place. So, you know, the plan is there. I think the federal government has stay true to their commitment to put it out. They have been very honest in saying that the plan is going to change over time. They've been great to meet with stakeholders for sure and have been really engaged with learning about how this is going to impact our education and our clinics like we have on campus here at Dalhousie University. And we will have to meet that need as it rolls out. So we don't know how it's going to look. But of course, that is a potential concern.
And back to Andrew's comment around careful planning will be critical in this, in thinking towards the future and how do we plan for that?
How do we make this sustainable?
Yep.
Yeah.
Good. Thank you. The next question is for Dr. Link. What role can philanthropy of donors play in supporting some of your innovative solutions?
Wow, how big are we talking about?
Well, I think sky's the limit.
Yeah,
No.
the sky's the limit. That's a good question. I mean, lots of research that could help the planning part and things, you know, can be done by researchers like some of the folks around the table and others. That's very helpful. And actually, Karlee and I were talking about our department is going to be funding at least one First Nation, one African Nova Scotia med student this summer to do a pediatric-related project to try to recruit them and get them interested in coming into pediatrics. So having summer funded projects and for the med students, another great idea. Also, our project, One Chance to Be a Child, that takes a little bit of funding when you're trying to develop good databases and find out about the social determinants of health and write good reports that are based on evidence with good solutions. All of those are project-based things, so healthy populations, funding for, again, research students paired with faculty or health directors like Karlee and others. Those are all good things that help teach the next generation of leaders, give them practice, but also get that evidence that we need to plan and advocate for resources too. So those would be some of the very practical things I would see.
Thank you. And I might just extend this question to Dr. Sarah Moore around how would philanthropy help with greater access and accessibility to physical activity?
Yeah, certainly. We know that most of the physical activity programs that are available for children with disabilities are funded through donations, and community-based organizations that receive donations. And so there's very few of the dollars that are coming from the federal or provincial government. Most of them are coming from independent donors. And so certainly, if we saw the benefits early on of engaging in physical activity and play, and perhaps how that could draw away from future healthcare demands and dollars, that would certainly be a worthwhile place to invest. And thinking about, of course, the social determinants of health, those earlier pieces where we could invest, again, fewer dollars to perhaps save more in the future would be really advantageous.
Thank you. All right, the next question, Shauna, what's next for the book Baby Smiles?
Great question. So a little bit more context. The The communities in Cape Breton actually received a kit. So it's a bag, and it has all the items that are in the book. So to further enable healthy habits. So an adult toothbrush, child's toothbrush, there's a teething toy in there, and a sippy cup for water, which we're promoting water is best, and a washcloth for inside the mouth. So we are hoping and working actively to gain some additional funding to provide the full kits to all the communities across Nova Scotia. We've had lots of interest in translating the book to other languages, so exploring that opportunity. And again, a good problem to have. We've had actually a lot of interest in people wanting to purchase the book. So trying to figure out and work with a local publisher on distribution. And we are also interested in creating, maybe I shouldn't give everything away. I won't get invited back. Puppets. So looking at how we engage young kids, especially within daycares and the Head Start programs and communities, and a few other little things that maybe I'll keep under my sleeve.
Oh, yeah. Keep us paying attention.
Exactly.
Okay, another good question coming in. How can someone who's a caregiver or not participate in the work happening at DAL to improve access to care? Not a small question.
Go ahead.
I'll maybe start and then you can jump in.
Yeah, you go ahead.
Perfect. There are several advisory groups that we have, certainly in the Faculty of Health, the Faculty of Dentistry, the Faculty of Medicine, as it relates to caregivers or others that have had experiences within healthcare to be able to provide their experiences and help to inform better care down the road. I have a couple of examples. So, for example, we have a James Lind Alliance research priority setting that's happening right now within pediatric rehab, where we have a group of parents, caregivers, and youth who have experienced disability, and we're trying to bring them together to inform research priorities for physical rehab and pediatric rehab. So that's one of the areas where we've had great engagement, and we've been working with the other advisory groups at the IWK that have been able to support and inform how we can best support our kids. In addition to that, we have one other project, and it's our youth-led project. So it's Amplifying Voices of Children with Disabilities. It's in partnership with the McKechnie Institute here at Dalhousie. And so we have received some funding to be able to have a youth advisory group, and it is complete of youth with disabilities. And so we have two youth, they're 16-year-olds, that are leading this group. And they've brought together a group of kids with disabilities. The first event that they're hosting is next Thursday. If you're interested, it's at the public library for free. It's a film viewing and panel discussion featuring our two co-leads. And again, being able to provide and amplify, provide the microphone and amplify the voices of people with lived experience, I think is a really critical piece to that. And so we are doing that in at least some settings, although I do think we need to do it even more so. Andrew?
Yeah, I would just add that we, at the IWK, we do have a family advisory council made up of parents and youth who have lived experience of going through an illness at the IWK. That's very helpful. And in terms of getting better, it's all about getting better. We were just accredited at the IWK, and we got an exemplary accreditation by Accreditation Canada. They reviewed our program. And everybody's going, that's great. But rather than patting ourselves on the back, I'm always asking, how do we get better? How do we get better as a province in healthcare, in social determinants of health, in pediatric care? So I'm looking at your QRS code over there, and it's funny because if you asked me, Andrew, I'm on service right now. I just came from the IWK on our 7th floor general pediatrics ward. If you said, Andrew, how satisfied is everybody upstairs family-wise, whether they're First Nation or African Nova Scotian or they're from wherever, Amherst, with the care that we gave them? And I said, I think they're satisfied, but I don't really know. And I found out we send the families an email a month after they've been there, and we get about a 10% return on that. And I'm thinking, is that really representative of how we're doing? as opposed to having one of those in the room, and just as you're about to go, you take a picture on your phone, you get 5 questions, tick, 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 tick. Did we manage your pain? Were we respectful? Was the food any good? Did you get good explanations? Did you get good follow-up care? Simple questions. So we can get better that way, and that's where we need families, Dean, and to participate in these volunteer groups at hospitals and other organizations to give us that feedback and design these better systems. Because I think we're doing okay, but I don't really know for sure. I hope we are, but I don't know. And I don't know in terms of how families feel when they come down to the IWK. I couldn't tell you if our First Nations families feel respected. I know we're starting to smudge now and have smudging ceremonies and things, but I don't know if we're doing a good job with our First Nations families, for example.
Okay. I've got lots of questions coming in, so I'm trying to pick them here. We'll go to the next one. Are there any programs currently in place in another province or country that you feel would be beneficial if implemented in Nova Scotia? And if we don't have an answer, that's fine too, but please go ahead, Karlee.
Yeah, I can talk. I know in British Columbia they have a First Nation Health Authority, and that's something that we're currently working towards on a First Nation level, Mi'kmaq Health and Wellness Authority, Dajigamic, to start working more closely with our provincial partners and IWK and trying to address those jurisdictional barriers that currently exist. I know it's a start, and I know it's still some time away, but I know that there have been benefits in that, another province like British Columbia, for example, and we're looking to them to kind of adopt something similar in Nova Scotia.
Okay, I know we're not going to get to all of the questions. I'll pick one more from our audience, and then I'll finish with a question. The question here is, why is Nova Scotia not providing early preventative screening for all children in order to provide supports in schools that may have physical or academic supports?
Yeah, I just... So normally what would happen if you had access to, when you go for your four-year-old needles, we have a system called the Rourke record, and that's on the electronic medical record now. And it has a whole bunch of questions about how the children are doing developmentally, physically, emotionally, and the physician or the nurse practitioner would go down through that list and try to identify any issues that the child may face before they go to school. So I feel like we have that now. I just feel like there's lots of kids who don't have access to primary care who don't get those screenings. And often if I would see a child, I didn't do a lot of primary care in Cape Breton, I did mostly consultant care, but if I did see a 4-year-old, and I recognized that, they didn't recognize their numbers or their colors or their shapes, then I'd make sure that I was going to write a letter to the school to be sure that they were tested and they had the support. So a strong primary healthcare system is already designed now to pick those up, Dean, but we just need to have, everybody needs to have access to it, in my mind. We are trying to develop. During the pandemic, we had quite a close relationship with the Department of Education. There was a group of pediatricians across the province helping figure out how we navigate schools opening and closing and masking and not masking and all that stuff through the pandemic. And we're hoping to continue that relationship and be able to liaise with the directors of education across the province so we can deal with issues like that. If they're seeing a lot of kids coming who have been unidentified, then why is that, and how do we do better as a healthcare system in getting them screened earlier? So we're trying to develop those stronger relationships now, but we can get better.
So maybe I'll follow that up, and I'm not sure if this was the intent of the question, but when I grew up, we had all the screening happening in the schools. So whether you had access to a primary care doc or not, there was at least some initial screening. Mm-hmm. Is there any of that happening, or any initiatives that are maybe pulling us toward that?
Well, we certainly screen before you start school. You get your eyes and your hearing checked before you start school. And at your 4-year visit, there's a whole slew of things. So I would say, yes, it is happening for most kids. Yeah.
Thank you. Any other comments from the panelists on that?
I would echo the same, that a lot of this comes down to access to a primary care physician that you're consistently seeing and who knows your family really, really well. One of the other places, and as you mentioned, our teachers, our early educators, our childcare providers are incredibly skilled, and they see our kids very regularly. Not all kids, though, and so certainly being able to have some further partnerships between our health and education can support increasing the scope of our childcare providers, of our educators being able to pick up on some of those things. But what about kids that aren't accessing those spaces? So that would be the challenge certainly as well.
What about those kids who are below the poverty line who can't afford a good breakfast or a lunch? I can identify those kids, but until Nova Scotia joins other provinces and we have consistent lunch and breakfast programs for everybody without stigma about offering stuff, I think that's another huge thing that we can do as a province, and we can do better as well. I think that's going to happen, but stay tuned.
Okay. So I'm going to have my own question, and we don't have a lot of time, so we're going to call it the rapid fire round for everyone. So many times when we hear the term healthy aging, people automatically think about older adults, retirement age. I think of it from birth. And in that health promotion space of, where we have kids transitioning into adulthood who are living healthfully and have well-being, what's the top thing you think that can promote healthy aging for our children? I'll start with I'm not going to poke anybody that would like to start with that one.
Healthy families.
Healthy families.
Because if the parents aren't healthy, the kids are going to be way behind the 8 ball. So in that healthy families, all the social determinants of health stuff, the support systems when people are struggling or they're in trouble, or they don't have equal opportunities, all of that stuff. So that's the core of it. I don't think we should be micromanaging the kids, let the parents do that part, but how do we support the parents and the families to make sure there's food in the fridge, that people have opportunities for good employment, free from racism, oppression, and have access to the services that they need to thrive.
I think to add to Dr. Andrelink's point on families, healthy childhoods is also another piece, because oftentimes, like I was alluding to and talking about, the colonial policies that have taken place, like residential schools, there's a generational of families, that have come from the residential schools that then they don't know how to parent, and then that parent and that child then grows, and then it trickles on, and they call it intergenerational trauma. So really to turn that and put that to healing, and to start healing those children's and families, to me, I feel would create an optimal healthy aging.
Thank you.
I'll jump in next. I would say that we really need to go back to protecting the rights of the child and for persons with disabilities. Canada has signed on to the conventions from the United Nations, and I think that we need to do a much better job of fulfilling our obligation to these kids and their families. And a lot of that also comes from putting your money where your mouth is, and making sure that federal, provincial, regional funding is providing funds towards programs that support children's health. And then in addition to that, I would say reducing the stigma for disabilities for the kids that I work with. There's ableism almost anywhere you go, and so just wanting to make sure that those kids are being able to access care in an equitable way.
Shauna, would you like to finish us out?
Hard to pick just one, but I think that the way that our oral health system has been structured has really kind of taken the mouth and put it outside of the body, in the way that you go to seek primary care from head to toe with the exception of your mouth. So I would say, changing that culture to putting the mouth back in the body and viewing oral health as overall health. And I think we are on the right track with that, but lots more to do.
Good. And we did our job. We finished on time. So well done. So I would like to thank our panelists and our audience for participating in our question and answer. So a special thank you to Shauna Hachey, Karlee Francis, Andrew Link, and Sarah Moore. So thank you for engaging with us. And
to you.
Thank you, Dean.
And thank you. Thank you. Do you want to make an announcement?
I have books.